Hi, I'm Dr. Jyoti Mishra,
I'm Dhakshin Ramanathan.
and we are here presenting the NEATCast. It's a podcast about mental health advances applicable to our daily lives. And today we're going to talk about this paper that came out in Nature Medicine in April 2025 by Furukawa et al. And it's about cognitive behavioral therapy. That should tell us why CBT is so important.
Yeah, so therapy is one of the most important ways that we can deliver mental health improvements for people. There are many different kinds of therapy. Therapy started with Freud. Freud was the first person who said, hey, we can actually talk with people and help them work through problems and make them feel better. Freudian therapy was there for a long time, and really Aaron Beck said, there's probably more helpful ways than simply allowing people to talk and process that Freud was talking about to help people improve symptoms of depression and anxiety in particular. And he started cognitive therapy, and behavioral therapy started shortly after that. And this was back in the 50s. So CBT, cognitive behavioral therapy, really started in the 50s and 60s and is one of the most important, widely used ways of helping people deal with depression and anxiety. And it teaches a lot of different therapeutic skills, including ways of reframing, thinking about things differently, and a lot of behavioral tools and strategies to improve mood and anxiety.
Yeah, and these skills are actually very much applicable in our daily lives, and that's why we're excited to talk about them. I'm also excited that this is a study that was implemented on a smartphone app that is highly scalable and accessible to people and addresses subthreshold depression that is not meeting the thresholds of clinical criteria, so often goes untreated or undiagnosed, and people do not have enough help for it. And the app was called the Resilient app, and it was a randomized control trial. That means that there were many control conditions that we're going to get into, and it was a really awesome international team, primarily based in Japan, but also really great clinical psychology and psychiatry researchers from around the world participating in this work. So really an example of a worldwide collaboration. So in the next slide, I will tell you a little bit about who took part in this study. This study was primarily based in Japan. There were 34,000 Japanese people who screened in for the study, and about 4,000 people met inclusion criteria and then were interested in doing all the study protocol parts. And so about 4,000 people enrolled in the study. They were about...
Which is one of the largest studies I've seen for cognitive behavioral therapy, even using digital tools.
And that's true. So that's why it is such a important paper, given that 4,000 people participated here. And again, the fact that they all had smartphone access made this possible. And they were about middle age, 50% male and female, 70% married, 70% educated, and about 90% employed. And we also see that as this study is done, about 84% were adherent to the Resilient app, which is a great number because, usually you'd see that there's fall off through therapy or treatment. So 84% adherence, which means 84% or 4,000 people adhered to the study protocol, is really a great number. And so
that's larger than most other digital studies, or is that comparable?
I think for a good app study, we do want numbers in the 80% or above for adherence. So when we do a feasibility for a study, we do look at how much people like to come back to it. And if they come back to it over and over and 80% of people can do the full study protocol, that's considered a good, nicely designed app. Okay, so Dakshin, you can talk us through the trial design. So this is a unique study which has 12 study arms. And the first few arms are the basic arms. Let's talk through those.
Yeah, so one of the things this study was trying to the study maybe was trying to do two things. One was just to show how effective are these digital-based or app-based cognitive behavioral therapy platforms. And the gold standard, of course, is working with one-on-one with a therapist. But over the last maybe decade, maybe more and more research is showing that these app-based tools can be effective as well. But the second major part of the study was really to say, what parts of CBT are the most effective, the most important? And this is helpful because, if you have somebody who has to learn 10 different skills or 15 different skills, it can be challenging. And there had been some previous research that suggested that certain parts of CBT were more important than others. Now, one of the strengths of the study is that they had so many people, right? They had 4,000 people. So they actually could randomize into a lot of different arms. And so they were able to address this question of which aspect of CBT is the most important, or they were trying to get to that. So they broke CBT into 5 different components. The first 2 components are probably what most people think about when they think about CBT. Behavioral activation. Behavioral activation is basically getting people to, in an organized and structured way, start doing things that they stopped doing when they became depressed. Usually it's around scheduling activities that are pleasurable, fun, activities that are more likely to make them feel better. Part of depression is you stop doing these things, then you get more and more depressed. The other part of it is what we would think of as kind of the other core component of CBT, cognitive restructuring or cognitive therapy. And this is when somebody has negative thoughts, maybe negative thoughts about themselves or about the world, or really has a pessimistic worldview. Are there ways to reframe those thoughts, to think about them differently, to challenge them? And that's what cognitive restructuring teaches people.
Yeah, so I'll tell you about the 3 other parts that were the core components. And again, just emphasizing why we like this study is because usually any therapy is thought of as this kitchen sink approach with so many different components, and to be able to really tease apart what works and what doesn't is really great. So Dhakshin talked about behavior activation, which is the meat of the motivation component, and cognitive restructuring is really reframing to more positive thoughts. And then the next component is problem solving. When one is feeling depressed, even small problems can seem like big problems, and they can lead to a lot of overwhelm. And so problem solving really is skills in breaking down any problem that you're having into smaller components and learning how to make measurable progress on those components, and how to practice breaking down basically bigger problems into smaller ones. So that's problem solving. Next is assertion training. And assertion training is really practicing how you can relate your emotions to others clearly, your wants, your needs, how you're feeling, what you may want from them, and really be able to assert yourself in situations when you're feeling emotional. And that can be very difficult and needs practice. And finally, a component of CBT is behavioral therapy for insomnia. Insomnia is when you have sleeplessness, and that is very common in depression. And so you're taught skills that teach you sleep hygiene, how to keep a conducive environment for sleeping, how to also manage your worry times during the day as opposed to the night, and really keep a time in bed for bed that is for sleeping only and not for thinking or staying awake at all. So it really helps you to maximize your sleep efficiency, which is how much time do you spend in bed just sleeping and not doing anything else? So here we talked about these 5 core components: behavioral activation, cognitive restructuring, problem solving. assertion training, and then behavioral therapy for insomnia. So these would be 5 arms of the study and about 300 or so people went to each of these arms. And remember that we said there were actually 12 arms in this study. And so there were 4 other arms that were combinations of these where pretty much what they did was combine behavioral activation, which has the largest evidence base as a very important component of CBT. They combined cognitive restructuring with behavioral activation as one arm, or problem solving with behavioral activation as another arm, or assertion training, or behavioral insomnia therapy with the behavioral activation arm. So there were these combination arms in the study. And then Dhakshin, you can tell us about the multiple controls, which is also something we really love about this study. And why do we need controls?
Yeah, so one of the most challenging things about depression research is that there's a lot of reasons why people might get better. One of those is just spontaneously, or you might say the natural course of the disease, right? So depression will sometimes just get better on its own, and people might do things and make it better. Depression is also sensitive, and highly sensitive actually, to placebo effects. So placebo effects are people think they're getting a treatment, and that can also help people get better faster than if they didn't think they were getting a treatment. So these are always challenging things to adequately control. And there are various controls that people use, and some of them we might think of as stronger controls, and some of them are weaker controls. The weakest control might be something where they say, hey, we're not going to give you any treatment at all. So that's kind of a delayed treatment control. A stronger control might be something where people think they're getting a form of therapy, but it's not really what we as the scientists or clinicians would think of as therapy. And that would be, for example, health information. So people get some information about things that they could do on their own that could help them feel better. They think they're getting a therapy, but they're actually not getting something that we think is therapy. And then they also include this kind of middle control. So one of the reasons why sometimes when symptoms look like they're getting better is just when somebody takes a survey again and again and again, things can change, and sometimes things get better on their own just from taking the survey. So they have what's called the self-check control, where they're basically just repeatedly taking the surveys. So again, one of the cool things about this study is they were trying to answer questions about efficacy, but also trying to answer methodological questions about how to design studies well. And one of the questions out there is like, what is a good control, and how do these different controls relate to each other? And this trial actually was able to answer some of those questions too.
Awesome, thank you. And so just diving into some of the results that we got from the study. And so usually the therapy period lasts about 6 weeks. Many studies have shown this. Other studies have done longer time periods, but 6 weeks is considered optimal, especially when we're considering a smartphone-based study. And in 6 weeks, we usually see high adherence. Like in the study, there was 85% if it's a well-designed app. And so here at 6 weeks, the results show that there was a medium effect size on depression outcomes, that depression did get better relative to the control arm, which was the delayed treatment or the health information provision control arm. And so a medium effect size is a good effect size. It's statistically meaningful. It really shows that, yes, people who use the app did get better than the ones who didn't use the app. They were in the control group. And this was for all CBT arms. And so this effect size is a standard measure that we can compare across multiple studies. And so any effect size that's above 0.5, 0.6 is statistically and very clinically meaningful to us. But like Dhakshin talked to us about what the self-check control was. And in that case, they were repeatedly doing the surveys again and again. So you get used to knowing what your symptoms are, and maybe you feel better over time just by doing them again, and you get used to doing them. And so in that case, if you compared the results of the app to just checking yourself again and again, self-monitoring, you got a smaller effect size of about 0.25. Now, in depression research, even a 0.25 effect size is considered meaningful, because without it, you're actually just suffering, and you don't have that many avenues for the depression to spontaneously resolve. So even many researchers have said that a 0.25 effect size is a good effect size. And then
I'll just say that with effect sizes, we're always balancing what are the other treatment options,
right,
and how risky or how dangerous is the treatment. And with subthreshold depression, a lot of times you certainly wouldn't get offered a medicine. Often you won't get a therapist either. So
right.
From that perspective, a digital app makes a ton of sense, and a small effect size sounds pretty good, given the likely risk of doing a digital app is pretty minimal.
Yeah, and remember that, as you use this app, or in the general case, self-check is just scientific control. You won't be taking these depression scales over and over if you were just in the general population and you're feeling slightly depressed. So delayed treatment or getting health information from the web searches would be the main control, and we're seeing high effect sizes there.
Good point, yeah.
The third thing that came out was that if you were to combine these different types of skills, so remember there were some arms that combined behavioral activation with problem solving or with insomnia therapy and so on, they did not see higher effect sizes with that. And there could be many reasons for that, and some could be speculative, like there's only so much time to practice and these skills in your daily life and incorporate these skills. So, every day you can only apply these skills to your daily life activities only so much. So maybe that doesn't give a bigger boost, but who knows, maybe if the trial was studied for a much longer period of time, then having a combination of skills would have been helpful. But at least at the 6-week mark, we don't see that there are greater effect sizes for doing a combination. They actually did do,
and everybody got behavioral activation, which is the key.
Yeah,
which people have said in the past is the most important part of CBT.
Yeah, so in the combination arms, behavioral activation and motivating your daily behaviors is so important that was part of all the combination arms. And so it was a very important part of the core CBT structure. And finally, the result that was emphasized was that similarly, the effect sizes at 26 weeks out, so this is about 6 months after the trial ended, you could still see prominent effects, which is very decent for having used an app to basically check in, and you receive notes and you receive exercises and skills, and your depression improvements are maintained for at least 6 months, which is amazing, without using other kinds of therapy or medications, and the symptoms don't get worse, which is really important to even reduce the clinical burden of depression, which is very high around the world. So Dhakshin, why don't you take us through some of the takeaways here?
Cool. So, probably the biggest take home of this, and what Jyoti talked about first, is a moderate effect size for digital apps, right? So digital CBT can be an effective and scalable solution for subthreshold depression that, frankly, in medicine probably isn't being treated. So these are people who are suffering with symptoms that are just kind of struggling, and this is great. This sounds like a nice way to help with those kinds of problems. I think the other key point is the effects lasted a long time. 26 weeks is pretty good. A lot of studies historically haven't looked that far out. They only look at 6 or 8 weeks. This is a constant critique of a lot of the psychopharmacology literature, but even the therapy literature. It's hard to look at these long-term outcomes. And they did, and they found that the benefits lasted. And you should talk about the digital tech piece because this is what you do.
Yeah, I love the part that they apply digital tech, use smartphone technology to get this app into many regions across Japan so that 4,000 people could really enroll in the study. And so really highlighting how digital tech is getting therapy to so many people at large scale. So there is a need for such treatments, and smartphone technology is enabling that. And then we just end with some limitations, even though this is such an impressive study with so many mechanistic components and a large sample size. You can't really blind people. So one of the main limitations was non-blinding, which is you can't tell people whether you're in the treatment arm or in the control arm. Well, people who got the app knew that they were getting some kind of treatment, so they were not blinded. There's no real aspect of personalization here, in that there's no way to know that behavioral activation should be right for you, so this is what you should get, or you should get insomnia therapy because you're having the most trouble with sleep. So there is no personalized matching to the needs of the individual, and so that's also a limitation.
I'm just going to comment on that. I think one of the weird things about research studies is you want to randomize. But in a clinical setting, a therapist, a psychologist might actually do a bunch of screenings and say, oh, wow, sleep is a major problem. Or, oh, actually, you're an adolescent who needs a lot of assertiveness training because that's why you're depressed. So coming up with a novel research design to be able to flexibly adapt to people's, I think is going to be a game changer too. What do you think about that?
Yeah, absolutely. And we're doing some of that work out here at NEATLabs, and maybe we'll get to present to you on that someday. And then obviously not every study can do a complex study design like this, which was sort of enabled by the large sample size that they had, which can still be a little bit of a drawback. How do you compare so many different arms? There are other skill sets beyond CBT, such as mindfulness training, compassion training, that have shown a lot of benefit in depression treatment. Those weren't compared here because they're not typical components of CBT. So we're not talking about other therapeutics that may, or therapies really, that could be helpful in subthreshold depression. There is no comparison to other apps, so this is just about the Resilient app itself. And also, this is just studying people in Japan. And then finally, we don't know how app-based therapies compare to in-person CBT, but we've already talked about how in-person CBT is less scalable, less accessible to people, especially in remote regions, and that perhaps there will need to be a digital component even if there was an in-person session, Zoom session, or a video session that needed to happen. So there's always a digital component involved. But these are multiple limitations the study has, even though this is a big study. And that's why science continues, and we continue to find out what are the best treatments for depression and other needed mental health conditions. So that's it for today. Dhakshin, thank you for your time, and it's been great to be here. And so you please follow the NEATCast, send us suggestions for what you'd like to hear. And thank you.